So the last talk will be about fibrinogen. You have understood that Diane likes very much factor 13, Jean-François factor 7, and myself fibrinogen. So we'll speak about these congenital fibrinogen disorders, and I will focus mainly my talk about clinical features, and I will say a few words concerning the management. And one of the reasons is because 2 days ago I spoke about the pathogenesis of these congenital fibrinogen disorders, so not to repeat what was said already. Here are my disclosures. And if you consider this rare bleeding disorder, which is a topic of this session, you see that based on the two registries, which is the one for the World Federation of Hemophilia and the one which is called the rare bleeding disorder, held by Flora Pevandi, the same kind of numbers you can find, and that's true roughly in every part of the world, I mean, at least where the tests can be done. So it's 8% roughly of this rare bleeding disorder. Would say better rare coagulation disorder, because it's really coagulation and not about platelets. So that's this fascinating molecule which encode from this chromosome 4 3 gene, which are called FGA, FGG, and FGG. And these three genes leads to this molecule which is rather complex, which is an hexamer, as we called it, which two copies of three polypeptide. It's called A alpha, B beta, and the reason why it's B and A that we remain that it until the fibrinopeptide is cleaved, it's still A alpha or B beta, but after that we call only alpha and beta and gamma. And you see that that's called the E region. It's the N-terminal part of the molecules, of the three chains, and that the D domain, which are the C-terminal part, and there is something very flexible here, which is called for the alpha chain. And the reason why we speak about congenital disorder is because there are mutations. And these mutations can occur in all the three genes. And you see the number, for example, of this recent review, about 212 well-defined fibrinogen disorders. FGA was 105, FGG 59, and FGB, 59, and FGG 95. And that's the way that it represented in this really nice paper. And there is a whole review in the seminar Thrombosis and Hemostasis this month about factor 13 and about fibrinogen disorder. And there are 15 chapters. And really, for those who like these two molecules, I encourage you to see these various papers. And this paper, what Marguerite Nerman-Arbes did, she, in black, that's the exon 1, in blue exon 2, etc., etc. And she listed all the mutations which are, for example, for IgG. In red, that's a null mutation or mutation leading to a type 1, as it was defined by Diane Nugent just before. That means a decrease of the molecule. And in type 2, it's in green, you have the various places. And in this box plot, you have what is called an hotspot. And you can find many mutations there. And it's here of FGG exon 8. And you see that 35% of the exons could have this type of mutation. I will not go further with the mutation again because it was the topic of another talk, but I will come back indirectly when I speak about the clinical features. So that's a classical way to represent that. That's a type 1 mutation, a decrease of fibrinogen and dysfibrinogenemia, where there is a discrepancy between the activity and the antigen level. I should say at this point that it's not as simple as that. And probably many of what we call hypercoagulable are indeed also dysfibrinogen. And it really depends on the definition. Don't stick only about this type of level based on the antigen levels. I just want to draw your attention about the diagnosis and the way we measure fibrinogen, which is really dependent on the machine and on the reagent that you use. And the numbers are really frightening. That's a NEQAS 215. And what you see, this type of number, that's the number of the lab. For example, we have measured in a normal person with a level around 2.4. You see the labs gives between 1.8 to 455. It's a 14% or more of coefficient of variation. And with this type of dysfibrinogenemia, which is a classic one, you see that, for example, the claws, you have a 143% of variation. So I draw your attention, and like Diane was saying, a few key messages in her talk concerning the diagnosis, which is apparently simple. I mean, you do PT, APTT, fibrinogen activity, fibrinogen antigenic, and then you do your thrombin time and reptilized time. It's not as simple, and be careful with the reagents that you use and participate to international collaboration in order to be sure what you are measuring. So my presentation will be divided into these 5 parts. First, a clinical feature either for the type 1 or for the type 2. I would say a few words like Diane did concerning the woman, because, again, women are affected as men. And the question which joins what Jean-François was saying, can we predict better than the mutation what's going on in this patient? Because you will see there is a diverse manifestation. And I would say a few words concerning the management. Already in 1945, I mean, it's already a long time ago, Anderson and others describe what was afibrinogenemia. And what they say, it's hemorrhagic tendency from birth, easy breathing, sometimes consanguinity. And clearly, I mean, there is a selection bias. But I draw your attention about that. 50% of what the patient had died in childhood. Sometimes people say afibrinogenemia is a relatively mild disorder. It's wrong. It's wrong. In some family, it's just a devastating disease. In other family, you have total lack of fibrinogen and without any symptom, which is very difficult to understand. You have clear dilation, no fibrinogen which is produced, and you have very, very mild manifestation, even no manifestation at all. A slow, very constant sedimentation rate, because red cells and fibrinogens are the 2 components of the sedimentation rate. And in all cases, an absolute afibrinogenemia and absence of clotting in coagulation test that still remain true. In these 2 series from Iran and Geneva, I mean, what we have compared, it's the various bleeding manifestation. And you see they are roughly parallel. I mean, it's the same type of manifestation, starting usually in infancy with umbilical cord bleeding, which is really a hallmark of that, and all the other various manifestations. And there is a strong correlation, at least when you compare the various levels of fibrinogen for patients with hypofibrinogenemia between the fibrinogen level and the bleeding events. At least there is some good correlation. There are some particular features concerning afibrinogenemia, and one of them is splenic rupture. And it's a dramatic event, and usually the people die. Here in this series, the outcome were relatively well, except this one. But I'm aware of other cases where, I mean, it was just a disaster, and partly depending the place where you live. Another thing which is more and more striking and more reported is the fact that these patients have some cysts, and these cysts are very particular. It is in long bone, as you can see here, and it causes bone pain. So if you have a patient with a fibrinogen disorder and which complains about bone pain, think about that, and there's a way to do some images in order to better see what's going on. We don't understand clearly the pathogenesis which is behind that. What occurs in some patients when you give them fibrinogen, they are much better and the pain disappears, which could be an hint to say that it's really linked to some bleeding problem, but it's not so clear. Another problem, and I just, as an example, show this person of 1972 that we know well. It's a patient with a real congenital fibrinogenemia with one brother with the same affection and 2 cousins also, and all the family have strong bleeding disorder. But this patient started with a lot of thrombosis. And without clear explanation, without any thrombophilia, without any substitution. He started by the pulmonary embolism, next cerebral infarct, aortic thrombi, and he did a new cerebral infarct. And that's a typical case, and many of cases are reported like that. And there was a poster in this particular meeting from Claudia Kanat from Lebanon, which reported 9 cases like that. And it's just frightening because you have to anticoagulate this person, which are prone to bleed also. And it's really a difficult choice. And we would like to understand better that why these people are doing this type of complication and thrombotic complication. One, and I say possible explanation because it's not as simple as that, but one possible explanation is because fibrin trap the thrombin. That means when you don't have any fibrin, you have an excess of thrombin, and this excess of thrombin could lead to some complications. And there is an increase of F1+2, and when you give fibrinogen, you decrease the F1+2. So there is one possible explanation, but there are other explanations. There is something very special concerning the mutation type 1 with hypofibrinogenemia. Most of these patients are asymptomatic. When they are very severe hypofibrinogenemia, some of these patients become symptomatic. But there is one thing which is particular, it's a hepatic storage disease. And what happens, all mutations occur in the same exon, exon 8 and exon 9 of FGG. And you see here the various, there are 6 well-reported families, but there are other cases with the same mutation. And there is an accumulation of aggregate in the hepatocellular endoplasmic reticulum. And that leads to different degrees of fibrosis and which can culminate in cirrhosis. And again, something very strange. In the same family with the same mutation, you have a very important cirrhosis. In the other member of the family, same mutation, you don't have almost any liver damage. So there is other things which explain again, this complication. But that's a clear when you have a patient with a fibrinogen disorders with understandable liver abnormalities, when you do the test, think about that, these possibilities. What about the qualitative deficiency? As you know, roughly 50% of patients with a dysfibrinogenemia don't have any symptoms. They are just asymptomatic or they are found because there is a workup with some other reasons. But in, let's say, 25% of them, it's a crude numbers, you have complications, and these complications are bleeding here, but you see this part here, it's thrombosis. And that's a problem of dysfibrinogenemia. Some of them bleed, some of them do thrombosis, and again, this very nice series from UK, from Shapiro, and the one we have in Geneva, roughly you can find the same kind of complications. Concerning the thrombosis-associated mutation in dysfibrinogenemia, they occur in some special sites again. You see here this thrombin binding site in the beta chain, and you see here in this very strange part, because it's a flexible part of the alpha chain, these two mutations, one is very well known, which is called Dussart or PARI5, which is linked with very clear complication in the family members. And I draw your attention because in the literature you will find many papers just saying that there is a thrombosis in one member of the family and we find a mutation and is a thrombosis associated. It's not like that. Because when you do and you apply some criteria, which is that the first episode should occur at relatively young age, true for venous or for arterial disease, there is the absence of other associated disease or thrombophilia. There is a clear segregation. A mutation lead to various members in the family, and the same phenotype in several families. And that's, you are allowed to speak about really an association between the mutation and the complication. In this paper, what we did, we have followed 101 patients, and the follow-up was about 9 years. And what you see in the follow-up of this patient, which is really impressive, the estimated cumulative incidence at the age of 40 years was roughly 20% for major bleeding and 30% of thrombosis. And what we have seen in this study, that the relatives of the patients who are totally asymptomatic, when you follow them, they become symptomatic, and they do more thrombosis than major bleeding. And concerning pregnancy, and we will come back concerning the problem of fibrinogen and pregnancy, which is similar to the one which was exposed by Diane concerning factor 13. Incidence of spontaneous abortion was this type of number, and PPH was like that. Hotspot mutation, I will come back with that. We are not predictive of either phenotype or outcome. And that's similar to what just Jean-François says about the factor 7 deficiency, the difficult link between the genotype and the clinical complications. There are something I can almost skip about that, but there is a paper that you will very often mentioned concerning also thrombotic complications with chronic thromboembolic pulmonary hypertension. And that's a group of San Diego. And they have published this paper, and with 5 different mutations in some particular place of the gene. We are trying now to repeat that with a series of patients with thromboembolic pulmonary hypertension. We don't find this type of results. Something also which is very strange, it's called dysfibrinogenemia and amyloidosis. And why did I put dysfibrinogenemia between brackets? That you find in all textbooks, dysfibrinogenemia and amyloidosis. But when you check the levels of the fibrinogen, most of these patients have a normal fibrinogen levels. That means it doesn't mean that the molecule is not abnormal, but when you measure it by simple measurements, the level is normal. The mutations are always the same, in this exon 5 of FGA, and which leads to an abnormal proteolysis. And these will lead to some amyloid fibril, and they will usually end up by renal failure, which is the most thing that you observe. But it could be a cardiomyopathy and other complications which touch various organs, like in amyloidosis. Concerning the woman, menometrorrhagia, which is really an important problem, hemoperitoneuron, with a very important pain. And when you see what happens concerning the pregnancy in patients, in women without any fibrinogen, they all are unable to carry on a pregnancy, and it occurs exactly what Diane Nugent was saying for factor 13. It's between the 5 and the 8 weeks that we observe that. That means there is no problem for them to have a baby, but to maintain the pregnancy for the various reasons that Diane just mentioned before, it's just impossible. So you need to give fibrinogen to this patient. If not, it's miscarriage or perinatal death. That's a woman we know well, and there's this woman who live in some part in Syria, has a clear dilation, and she was able to carry on her pregnancy because she received fibrinogen. But what I would like to mention you concerning this particular woman is 2 things. The first one, in her family, there is almost no bleeding, as I told you in the beginning. And what she did after the pregnancy, extensive PA 1 month postpartum and recurrence after. So again, that means you have to be very careful with these patients when you substitute these patients, and to follow them and to give some prophylaxis in some, for example, in the postpartum. Hypofibrinogenemia women can also have a problem with pregnancy. Usually think that with a 1 gram level it's enough. It's not true. There are some women that we follow who are just unable to carry on a pregnancy. And when you substitute them, it was possible. So consider factor replacement in selected cases, not in all the cases, absolutely not all the cases, as well as regular monitoring of fibrinogen level and ultrasound assessment in this woman. Concerning the dysfibrinogenemia, the only predictive risk that we could find, it was a bleeding phenotype. That means a personal or family history, in order to show that there is an increase of the postpartum hemorrhage. Again, the classical mutation FGR35, which is at position 16 in the cleavage site, or this one, which is close to the TOH terminal, they were not predictive. And a similar question that Jean-François raised, how can we go further? We are saying that the mutation explains some of the disorder, fibrinogen disorder, amyloidosis, and some cases of dysfibrinogenemia. But for most of the cases, it's not enough, and it's not the real explanation. So are some global assay more useful? There is very few publications concerning that. There are really 3 publications. One example is what is called fibrinogen pulse, and this fibrinogen pulse is associated with thrombosis. And when you do an extemp and you add TPA, you see clearly the difference between a control and really with a prolonged and a poor fibrinolysis in these patients. But there are few studies right now, and obviously, you cannot study the afibrinogen person. It's really for dysfibrinogenemia that it could be of some help. What we do in Geneva, and with the collaboration of Robert Arians in Leeds, but Alessandro Casini, who works with me, went to spend 1 year there, and we are doing many other tests to try to see if the fibrin structure and what are going on in the clot could learn more about the prediction to have a bleeding disorder. And for example, in these 24 patients with dysfibrinogenemia, what we have shown concerning the maximal absorbance, that means turbidimetry, or ici you measure the permeability, here you measure a clot lysis time. What was the most important and the main difference was really the permeability. And here you have some example in the microscope electronic. There are many other tests. There are other tests, and we use more and more what is called thermodynamics, which for us, it's really interesting. It doesn't mean that you have to perform all these tests for all the patients. I mean, it's really something very specialized. The information that we can get right now is not really so important in order to promote all these tests, but just think about that. And the variable clinical symptom could be explained by other things, as you all know. I mean, it could be acquired causes or could be other genetic explanation. So it's not a simple explanation when you have a fibrinogen level. Concerning the perspective, and that was mentioned at the end on the last slide of Jean-François, he says that participate to international registry. And that's one of the registry, which is for the factor 13 or for the factor of the fibrinogen. And in this registry, what we try to collect is the patients having fibrinogen deficiency. And we follow this patient, and that's a common work of many centers. A few words concerning the management, and I will end up by that. There is no evidence-based medicine because of the lack of numbers of patients. But again, with this registry or with international collaboration, we will be able once to be a little better. Prophylaxis in case of severe and recurrent bleeding, there is a kind of agreement that was for Munford. We reviewed that recently, but I will mention you something else. Prefer low dose and frequent replacement. And that's a common sentence. The management should be individualized. You find that everywhere for many disorders. What we did recently, and with the help of 21 experts from Belgium, France, and Switzerland, we did a Delphi process because there is so poor information and all evidence has 2C evidence. So we did the first one, 65 questions on prophylaxis, bleeding, surgery, pregnancy, and thrombosis. So we took 5 items. 15 questions were with more than 80% of agreement, so we kept this question as statements, and we did a second round, and finally we ended up, and this paper will be published soon with 22 statements. And I just listed here a few statements concerning the fact that, for example, in afibrinogenemia, there was a consensus that not to start a primary prophylaxis in a child, but the way that something occurs. And the reason is because, at first it needs to have a blood puncture, etc., etc. And secondly, we are also afraid by the clinical complication linked to the thrombotic problem also. So, that was a kind of statement, and you see that during prophylaxis, target level should be 0.5. Adaptation of dosage, the frequency of infusion, rather than fibrinogen amount should be modified. That's again linked to the risk of thrombosis for some of these patients. Moderate hypofibrinogen patients without previous bleed may not receive fibrinogen in the case of low bleeding resurgery. And finally, monitoring the trough level should be performed at least once a month during pregnancy, and a fetal growth and placenta close monitoring by ultrasound is recommended. There are many other statements in this paper. And what we are trying now, and that's a call for some of you who would like to participate because we need to have more patients, but there is no data concerning the quality of life of these patients, which is an important aspect for these patients. And so there is an ongoing study, and we are trying to recruit at least 150 patients. And you see here the steering committee, and Alessandro Casini tried to collect from everywhere, with informed consent, etc. So in conclusion, I will just remind you a few things. Congenital fibrinogen disorders are both bleeding and thrombotic disease. There are other complications I mentioned you. The mutation, global and other assay animal models may help to better predict the clinical phenotype. In Geneva, we are working with the zebrafish, and especially we are working with wound healing and things like that. And larger series, and that joins what Jean-François was saying at the end, are going to better assess patients' phenotype and their management. I will just end up by this slide showing the various collaborations that we have, and obviously, I mean, what I was able to say today is a result of all the discussion with the people who send us samples, and we discuss together, because it's not with a limited number of patients that we have in Geneva that we will be able to do anything. So thanks to all of you. Maybe some of you are in the room. And thanks if some other would like to participate to any study. Thank you.